Okay, perfect. Let me see. Okay, cool. Awesome. All right, so let's just go ahead and get started. I will eventually take myself off this video, so it'll just be your beautiful face and your presentation. But I just wanted to welcome everybody for joining us today, and thank you, Marcus, for joining us as well. My name is Noemi. I work on the LX Med team, and the webinar is brought to you by the LX Med Network, which is our new app that we just launched. So for today's topic, we wanted to acknowledge and highlight National Latinx AIDS Awareness Day, which is today, with today's webinar, which will be brought to you by Marcus. He will be focusing on HIV prevention and medicine, which is something that's not very often talked about in our community, but just in general as well. And a little bit about Marcus, I'm sure he'll go into details, but he is a family medicine physician in Los Angeles, and he is very, very dedicated into bringing health awareness and equality to the LGBTQ community. And just a few things for everybody that's on. Thank you for everybody that I kind of see you guys trickling in here. For the first 40 to 45 minutes, we'll have Marcus do his presentation. And then for the last 10 to 15 minutes, we'll be taking questions. So I'll just come back on the audio real quick to read the questions to Marcus so he can focus on answering those for you. But if everybody could please drop those questions on the Q&A, it's on the bottom of your screen rather than the chat. That way it's just easier for us to manage those questions. That would be great. And other than that, I think we're all good to go. So I'm gonna go ahead and just stop my video, I guess, and mute myself and give you the floor, Marcus.
Okay.
Okay.
So I'm still sort of new to Zoom, so forgive me, anybody, if it takes me a bit to figure it out. And then if you, like you said, if you see anything in the Q&A, just let me know. And then I like to have my presentations be more interactive. So I will, from time to time, switch back from the presentation to myself, since I am a little animated, to answer any questions that you guys have during the presentation. I'm Marcus Tellez. I'm a family medicine physician. I just finished my residency in Florida, and I am starting my first grown-up doctor job in Los Angeles. So let me share my screen with you guys. Hold on a second. Okay. And then, perfect. Does everybody see my screen? The HIV prevention slides? Sorry. Okay, let's see. Yes, okay, everybody can see the slides, perfect. But now I can't see my mouse. Okay, we'll play this by ear. Okay, so HIV prevention is something that I'm super passionate about. Here are some of the topics of discussion. If you guys have other questions, obviously feel free to ask them and we can go through those questions as well. So like we said earlier, today is National Latinx AIDS Awareness Day, to highlight the disparities that we face in our community with HIV AIDS. I have a lot on the slides. You can feel free to read them. I'm not going to regurgitate them word for word, but I just want you guys to get the point, is that still in 2020, Latinx individuals still face pretty high rates of HIV AIDS. And so we as healthcare providers and social workers, anybody in the healthcare field that addresses patient needs, we need to focus on HIV AIDS, because in this day and age, there's really no reason why we should have new rates of HIV when there's so many ways to prevent it. So HIV disparities, as I talked about. Hold on. Sorry, I'm trying to figure out this mouse. I have the mouse, but now it's like hidden. So I can't move the chat out of the way, sorry. Okay. Well, more chat. Okay. No, that didn't help. Sorry, the chat is literally right in front of my slides, so I can't see anything. Okay, I'm gonna try to wing this. Sorry, guys. You guys can still see my slides, correct? I can't unshare my screen because the mouse like doesn't show up on my screen anymore. So we'll just keep going. So as the slide shows, there's significant disparities, particularly with Latinx, gay, and bisexual men. We have a 1 in 5 lifetime risk of acquiring HIV. For Black, gay, and bisexual men, there's a 1 in 2 lifetime risk. And for white, gay, and bisexual men, it's a 1 in 11 risk. As we go through the slides, I'll show you the comparison to the general population, but we still have significantly higher rates. Again, here's just more statistics from the CDC. Despite how many ways we have to prevent HIV, we still struggle with getting those new diagnoses down. Actually, over the past few years, the new rates of diagnoses have been stable, but there's still a lot of people who haven't been retained in care, haven't been virally suppressed, and let's address some of those reasons why. This is just a statement from the American Academy of Family Physicians, essentially saying that nowadays there are such good medications for HIV that people can live full life expectancies as opposed to previously. So I can see your guys' chat. I can't access the Q&A, but I just wanted to ask you guys, why do you think in 2020 there's still so much stigma associated with HIV, especially within minority communities, Latinx communities? What do you guys have any feedback or thoughts as to why we still have so much stigma? Machismo, yes. Cultural, machismo, religion, lack of education. Yeah, those are some great points. I feel like yeah, it's true. I have it somewhere later in this PowerPoint presentation, but actually, even amongst healthcare providers, they did a survey, and a lot of healthcare providers still, despite our training, still get really uncomfortable when talking about sex. It's part of our jobs, but still somehow we are not really comfortable with it. So that's something that I think we need to work on in our healthcare training, whether it's medical school, PA school, nursing school. We need to talk about these sort of things and normalize it. Okay, so I have a little question for you guys here. I'll let you read it for a bit. 19-year-old female. She presents for a well woman exam. Sexually active with only one partner. Never been treated for any STIs. So based on the US Preventive Task Forces, what would you guys say is the correct answer? Yes, I see some E's. Okay. And then, so I'll get to that. E is the right answer. And then I'll give you guys this one regarding a medical student. What would you say is true regarding antiretroviral therapy? I see a B, I see a C, I see a C. So yeah, good job, guys. So in the first question, E is correct. Everybody, according to the US Preventive Task Force, everybody should be screened for HIV at least once in their lifetime. And then the recommendations from there get vague. If you have a patient who has sex more often or is prone to other STIs, you can talk about screening them for HIV more often. And then for this question, the actual answer that was given on the practice exam that I took gave C. But as somebody else earlier in the comments wrote, B is actually a correct answer as well. So we will continue to talk about that. I just wanted to give you guys some HIV basics. So as you know, HIV does not equal AIDS. HIV is infection with the virus, while AIDS is the outcome of having this virus affect your immune cells, your CD4 cells. So it's important that we learn and use a language that doesn't connotate them as the same thing. Here's a little graph on the rates of HIV from 2016. As you can see, we still have a high prevalence rate in the South, particularly Florida, where I'm from. More facts. Right now, about 1.1 million people in the United States are living with HIV, and 1 in 7 do not know that they are infected. As we talked about earlier, in gay Latinx men and bisexual Latinx men, their lifetime risk is 1 in 5, compared to the overall US population is 1 in 99. So that's a huge gap in care and disparity. Why do we think that there's more cases in the South? I think it probably has to do with what everybody was talking about earlier. I think culture, conservative views, it's the Bible Belt. There's less discussion about sex topics. Actually, I don't know the exact number off the top of my head. I was just talking about it with somebody. Don't quote me on this. It's either 27 or 29 of the 50 states requires sex education in public schools, whereas the other states don't require that. So again, in places where we don't have sex education, sexual health education, we don't talk about these sort of things. I grew up in Florida. I had a sex ed class that they briefly talked about sex, but never mentioned HIV, never mentioned STIs. It was not really conducive to learning. And so then this slide, I just wanted to point out that the life expectancy with people living with HIV has significantly improved over the years. We have much better medications now, and people have a significantly improved quality of life. Like I said earlier, there's still a lot of disparities amongst minorities, amongst gay, bisexual men, and particularly also with Black women. Okay, so what are some ways that you guys know off the top of your head that HIV is transmitted? Okay. Yes. Mm-hmm. Good answers. So let's talk about, yes, those are all great. So number one, always talk about sexual transmission. Sexual transmission is the most common transmission that HIV is spread through. Either partner can become infected, particularly with men who have sex with men, gay men, bisexual men. There's this thought that the receiving partner in anal intercourse is the only way that you can get HIV. And while having anal intercourse and being the receptive partner puts you at an increased risk of HIV transmission, both partners can transmit to each other. And there's some studies showing that having an STI and having genital ulcers around the same time as sex can also increase the rate of transmission. IV drug use. My screen is blocked, so I can't say the percentage off the top of my head, but IV drug use is a method in which HIV is spread. Do you guys know of any ways that we can reduce the rates of IV drug use, HIV transmission? Yes, needle exchange programs. That is exactly what I was looking for. It's in some states it's frowned upon. In some states they have great needle exchange programs which have shown to reduce the rates of new HIV infections. So as healthcare providers, I really think that's something that we should advocate for our patients. Someone mentioned mother to child. With ART now, the rates of mother to child transmission has significantly decreased, less than 2%. So that's also why it's so important for all pregnant women to have an HIV screening at their routine OB visits and to make sure if they are positive that they remain on their medications. Blood transfusions, not really common anymore. I couldn't really find exact data on if this ever happened recently. I think donating blood, particularly for gay men, bisexual men, is sort of not allowed in the US, to say the least. I think recently they changed it from you have to be a year without sex to 3 months without sex if you're men who have sex with men. So there's a whole controversy about that, but blood transfusion, realm of possibility, doesn't really happen these days. And then healthcare associated. I particularly wanted to talk about this because even within healthcare workers, there is still stigma against HIV patients and the fear that HIV patients will transmit HIV to healthcare providers. And that's really something that I like to break down for people. So since 1991, there's really only been, and of course I can't, you can read the slide. I'm so sorry that I can't read my own slides. Since 1991, that's 58 cases. And then only one case since what year? 1999. Thank you. You guys are wonderful. I appreciate it. So yeah, I mean, there have been cases in which healthcare workers did acquire HIV. But since 1999, there's only been one case. And that's because antiretroviral therapy has become so great that even if somebody is HIV positive, the risk of transmitting to anybody else is so low. Does anybody want to tell me what the percentage or the risk of you acquiring HIV, even if you get poked with a needle stick? 0.3. Thank you. You guys are wonderful. I really appreciate our collaboration in this presentation. And then non-intact skin or mucosa, again, very, very low risk. And then if you have intact skin, there's virtually no risk of HIV transmission. I just wanted to harp that point home because I've even worked with healthcare workers who wouldn't even shake the hand of an HIV patient. And that sort of message, particularly from healthcare workers, like that leaves a bad taste in the patient's mouth, that makes them resistant to want to continue care where they're at. It makes them wary of other healthcare providers. And it's 2020. We should not be making our patients feel less than if we want to improve their outcomes and improve the outcomes of everybody as a whole. I think if you're going to be a healthcare worker, you have to shut that part of your brain off, that those negative thoughts and negative stigma towards patients, because that's why you go into healthcare. You know, you go into healthcare to take care of people, to help people. And I can't read what this next slide says, but I'm sure the rest of you can. Okay, so as we talked about earlier, U.S. Preventive Task Force recommends everybody gets tested for HIV at least once, including pregnant women. You use these days you have the 4th generation HIV test, which is very, very, very accurate. There are at-home testing. The first one, the home access HIV test that takes a blood sample from your finger, that used to be available in the US, but recently, over the past year, I've not been able to find it online or get access for patients about it. So I don't think it exists anymore for some reason, at least not in Florida when I was looking for it. The OraQuick is a mouth swab test, and that's over the counter. You can buy that at Walmart, Walgreens, CVS. It's pretty accurate. I value the availability of home testing for patients who don't have access to a provider, patients who don't have insurance. But at the same time, I don't like them for the reason of, if you're home alone, you don't have a good support system, you don't have people around you, you don't have that provider to talk to, if for whatever reason the test comes back positive. They do have telephone lines through the OraQuick system so that you can talk to a counselor or therapist if your test does become positive. But I mean, I prefer having the provider-patient interaction, but these are other options for people who don't have that access. So just a brief overview of the overall management of HIV. Regardless if you're going to start treatment for somebody or if you're just meeting for the first time, you always do a thorough history and physical, and labs are going to be here if you guys want to screenshot or write those down. They're just important labs to get for your patient if it's your first time seeing them or the first time that they have a new diagnosis of HIV with you. Just some important things to get done for them just so that they can start on treatment quickly. Does anybody have any questions? Immunizations, make sure they're up to date on their immunizations. Certain CD4 counts, you have to make sure they're greater than 200 for certain live immunizations. Prophylaxis, if their CD4 count is less than 200, less than 100, you have to worry about these different organisms and give them the prophylaxis to prevent any of those infections. Can certain ARTs help you get undetectable quicker? I really wouldn't say that per se. I mean, the guidelines are for triple therapy right now. So there's a whole different set of medications that you can use, but usually if you use the triple therapy, most patients will get undetectable pretty quickly. It just depends how long they've had HIV, how much viral load they've had, how much it's impacted their CD4 count, and if they have any resistance to medications. If they've been on medications before, then they stopped for a while and then went on another regimen, that can predispose them to getting resistance. But usually with the right medications, they'll get undetectable pretty quickly, within a month or so. And then again, even, I don't expect all of you to learn all the ART, learn how to treat HIV, but regardless, if you're gonna be, whether you're gonna be a primary care provider or any other sort of type of healthcare worker, you should treat these patients just like you would anybody else. Make sure you do all their primary screenings, counsel them about their mental health, talk to them about their blood pressure, tobacco cessation, all of that. Are most HIV patients treated by PCPs rather than specialists? Well, that's a good question. It depends. I think there's a lot of infectious disease specialists right now that do most of the HIV management. I think it depends where you're at, what kind of city you're in. For example, I did a family medicine residency training, and part of the family medicine training did not include specifically HIV management, but I went through and did some other CME courses. I studied on my own. The place that I work at now, they have providers that have been around since the beginning of the AIDS epidemic, who have gone through all of this and are helping me learn the HIV medications. So it's a matter of where you do your training, how much extra training you're able to do yourself. But there are definitely PCPs that manage HIV without an infectious disease specialist. How do you approach handling the patient's mental health when they get the diagnosis? Curious about the conversation and what best practices you recommend. Well, in most states, I think all states, before you do an HIV test, you have to get the patient's consent. So when you get that consent, I think it's important to have the discussion. Well, if we're going to do this HIV test, I think it's important, if there is a positive test, we have this discussion in person. You talk to them about HIV prevention. You talk to them about what would their reaction be if they did become positive. We all have different ways of approaching those things, but it's just a matter of how comfortable the patient is with you, how comfortable you are talking about these things. I think it's important to build a relationship with your patients and let them know that you're there to support them, regardless of what happens. How do you approach talking to a patient about HIV AIDS, especially if you can tell they feel uncomfortable? That is hard. I have had one very tough experience with a patient who was in complete denial, and before the positive test came back, we had a great relationship, and then afterwards they sort of shut down, and I don't think I was able to get through to them. Eventually, upon hospital discharge, this was in residency, they were started on medications, and they were able to follow up with the infectious disease specialist. But it was really hard to get through to that person. They did not deal with it well, despite our conversations beforehand. And everybody deals with grief differently. So you have to show that you care and support your patients, but at the same time, some of them need their space and the ability to process things on their own. But it's always important to check in on them, make sure they're having their routine follow-up. What does living a life with HIV look like today? Well, we can get to that. So really quick before I answer that, so previously there was this train of thought, ART is antiretroviral therapy. It's medication for HIV. Yeah. So years ago, it was thought to wait for the CD4 count to go a certain level, or a viral load to be a certain level before you start ART. And nowadays, actually, as soon as you have somebody diagnosed with HIV and you get your labs back, start the medications as soon as possible. They found that patients who start ART, antiretroviral therapy, or HIV medications immediately, they significantly have improved quality of life, less likely to have other infections. So yeah, living with HIV today is like living with any other chronic condition, like living with hypertension, living with diabetes. It's a life where you have to see your physician or healthcare provider, PA, nurse practitioner, what have you, see them regularly, take your medications regularly. And for the most part, you can live a long, happy, healthy life. The quality of life with the new medications that we have significantly improved for people. And so where patients were dying very young to AIDS previously, now I've seen patients in their 70s and their 80s on ART living long, happy, healthy lives. I am getting a little pop-up saying that there's some Q&A questions, but it won't let me check on it. Does anybody, any questions in there that haven't been addressed in the chat?
Hey, Marcus, can you hear me?
I can.
Okay, I'm going to chime in real quick so you can answer these questions.
Thank you.
Somebody asked, what are some practices in use today to increase patient medication compliance, especially among minority patients?
Yeah, I think number one, you have to have an environment in which people feel like they can trust you. If you don't develop that level of trust with somebody, they're not as likely to listen to you or want to come back to you. So you have to make them feel welcomed, make them feel like they can talk to you about things. I think, especially as physicians, sometimes we have this tendency to talk a lot of medical jargon, and that's something that I make sure that I have a lack of medical jargon when I speak. I'm very just colloquial. So obviously you're all educated people, but you have to make sure you talk in a way that somebody who doesn't have years of medical school, PA school, nursing school experience can understand you. And I think being able to communicate with people and making them feel welcome, number one, is a huge thing. Number two is education and talking to your patients. Don't just assume they know what HIV is. We throw around a lot of words to patients and just assume they get what we are talking about, and we don't sit down and really explain things. And I know that our healthcare system is kind of in a way that we don't have a lot of time anymore to see patients. Like, insurance companies are sort of pushing us to see patients in like under 20 minutes, which is obviously frustrating. But you really have to make sure they understand what is going on. Just like diabetes, like I've had patients come in and we sit down, we go over their labs. I'm like, okay, your A1C is 7.5. We need to work on that. And I'll ask them, do you know what an A1C is? And they've had diabetes for like 10 years. And they'll be like, no, nobody's ever actually told me what an A1C actually means. So it's important to get a good understanding of what your patient knows about their diagnosis, so you can educate them. And when you educate them, again, that's another step you can do to build trust and to build their understanding of what's going on. I think those are the big two things, is making sure that there's an environment that they feel welcomed in, and that they're informed of their diagnoses, the importance of being on their medication. So yeah. And then I just saw a question in the chat, is ART the same thing as HAART? Yes, you can use them interchangeably. I think the HAART used to be more commonly used, and then nowadays, just because ART is shorter, it's become more commonly used.
Quick chiming in as well. Somebody else asked, are there any side effects of ART?
Yeah, so the medications have significantly improved over time. The original medications had a lot of side effects. It didn't make people feel good. Some people chose to not take medications just because how bad they felt: nausea, vomiting, upset stomach, diarrhea. But now the medications are really, really great, that most patients don't report many day-to-day side effects. Some of the medications, which we'll talk about soon, they can have an effect on the kidneys. They can decrease bone mineral density. So those are just some things that you monitor routinely with your patient and their labs when they come in. So yeah, great questions, guys. There's some clinical trials. I'm not gonna go over them significantly in detail. I just like to present information so you guys know that I'm not just talking just to talk. Like, I like presenting the reasoning why we have the guidelines that we do. So again, like I said, they used to just wait for the CD4 count to fall down to a certain level before starting medications. And now they've shown in studies that the sooner that you start medication, the better survival rates that you have for patients. And then here's another study sort of proving the same exact thing. Actually, this study showed that earlier that you start antiretroviral therapy, the less likely that the HIV patient is going to transmit HIV to other partners. And so anybody that doesn't know, HIV serodiscordant couples, that means a couple that one has HIV, one is HIV positive, and one is HIV negative. Again, another trial showing that patients, sooner that you start medication, better outcomes. So some ways for prevention. I gave you a whole big spiel about HIV, some basics. I could go into a lot more detail on medications and therapies, but I just want to get some bare bone, just basic facts for you guys. Out of curiosity, if people want to in the chat, where are you in life? Are you pre-med? Are you med student? Or PAs, nurses? What are you guys doing? Med students, pre-med, pre-PA? Awesome. MCAT studying, bless you. Awesome, cool. Okay, so let's talk about prevention, like the bulk of what I kind of wanted to talk about. So HIV PrEP. How many of you guys have heard about HIV PrEP? Yes, 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 a bit. Yeah, okay. So HIV PrEP, it is a medication to prevent HIV. So it's pre-exposure prophylaxis. This has been around for a long time. I believe the Truvada has been approved for HIV PrEP since 2012, and Descovy actually got approved last year for HIV PrEP. This is anecdotal, I have a lot of friends who wanted to go on HIV PrEP, and their primary care providers were like, I don't know anything about that medication. I don't feel comfortable prescribing that medication. I've had other friends who were on PrEP and they saw a healthcare provider, and their healthcare provider just assumed that they had HIV and they were on medication for HIV. So just as a heads up, for most people who have HIV, they're usually on at least 3 medications. There are some medications now approved that are only 2 medications for HIV, but if somebody is just on Truvada or just on Descovy, it's not for HIV treatment, it's for HIV prevention. So they are drugs that have been around for a long, long time. And so we've studied now that when somebody takes these medications daily, they reduce the risk of HIV infection through sex by over 90%. So they're great medications to prevent HIV spread. So Truvada and Descovy, they're 2 medications, 2 HIV medications in 1 pill. So you would prescribe 1 pill daily. You can give your patients 3-month prescription. And so the caveat is that every 3 months, they do have to come in and have HIV testing. You should also check their hepatitis B status. Most millennials and younger got hepatitis B immunizations at childbirth. But it's important to check Hep B immunity status before you start this medication, solely because if somebody does have hepatitis B or becomes infected with hepatitis B while on this medication, if you discontinue it, it can flare up the hepatitis B. So it's really important that you know that beforehand. You monitor their kidney function. The medications can have an effect on the creatinine. Truvada more so than Descovy. Descovy has less of a renal side effect, but again, most patients don't have that issue. And then safe sex practices. It's actually a term that some people get offended by now. I prefer the term responsible sex because there's a lot of shaming of sex in general, and shaming of condoms, shaming of not using condoms. So I prefer to talk to people about responsible safe practices, meaning you know your HIV and STI status, you get tested frequently, you have open communication with your partners, you have consent with your partners. I think that is an important way to drive home sex positivity to your patients so that they feel comfortable talking to you, they feel comfortable talking to their partner, and we can decrease some stigma around these sort of things. I see in the chat somebody wrote about PrEP 211 method. And so for those of you unfamiliar with that, there was a study done in Europe called the IPERGAY trial. And so we've known for a while now that with the Truvada and Descovy, if you use it every day, you reduce your risk of HIV transmission. But they did a trial with a small group of doing Truvada 2 pills the day before having sex, 1 pill the day of sex, and 1 pill the day after having sex. And that study showed that that did prevent the transmission of HIV to non-HIV infected patients. It is promoted in Europe, but in the US, it has not been approved, FDA approved for that. I think it has a lot to do with, I still think it has to do with stigma, sex stigma, HIV stigma, slut shaming. I mean, there's a lot of connotations as to why we still don't recommend PrEP 211. Based on the studies, it works. It's a small population, but patients can use it in this method, I tell them that it is an option, but I also explicitly talk about that it's not FDA approved in the US to be used that way. But I have met patients that do use PrEP in that way. Some trials, some study numbers, for those of you who like numbers. But pretty much in the study, they saw that in this IPREC study that there was a 92% risk reduction of HIV acquisition for those taking Truvada. And that was the important thing of the study. For those who were on Truvada and had detectable drug levels, meaning that they took it consistently. So this study looked at using PrEP every single day as opposed to the 2-1-1 method. Again, another study. Okay, here's something that people won't talk about much. But how many days would you say for optimal protection to take PrEP? 7, B. And how about, does this one say anal? Or no, vaginal. The first one's anal and this one's vaginal. How many days would you guys say for vaginal? Oh, and this was a good one. How many cases of PrEP failure? I see a B. Okay, so for anal receptive sex, ideally, someone should be taking PrEP for about 7 days consistently. Studies show that Truvada and Descovy, they reach good blood levels like instantaneously upon like taking it within a day or so, but for the anal tissue to be completely absorbed, so to speak, with the Truvada, takes about 7 days. But we still believe that within a day or two of taking PrEP, that patients have that protection. And in vaginal tissue, it's found to take up to 21 days. Again, I'm not saying that women who take PrEP can't have sex prior to that, because it is found in the bloodstream much, much sooner, but this is just what they've seen with the actual vaginal tissue to fully absorb the PrEP. And there have only been 3 cases of failure. And from what I've read, they were either patients who were not taking the PrEP consistently, or had acquired in a strain of HIV that had resistance to multiple medications. But again, it's not a common thing. Has anybody heard of HIV PEP? And what would you say PEP stands for? Post-exposure. Yeah, good job. So post-exposure, yeah. So you have your pre-exposure, so meaning you have protection prior to any contact with HIV, and you have your post-exposure. Post-exposure prophylaxis is for after you've come in contact with HIV. So healthcare workers who may have had a needle stick, patients who may have had unprotected sex and are worried about a partner who later told them they have HIV, or they, in worst case scenario, a case of rape. Post-exposure prophylaxis should be given within 72 hours of sex that if somebody is worried about having received HIV, or from healthcare workers. Again, the needle stick risk is very, very low. But if somebody just wants to have that peace of mind, essentially it's the same medication as PrEP. It's Truvada plus One of these, either dolutegravir or raltegravir, those are integrase strand inhibitors. That's the type of HIV medication they are, and they work very, very well. We don't have any human studies about PEP. PrEP, we have tons of studies. We have animal studies for PEP. But again, in the age of antiretroviral therapy and how good it's gotten, most patients who are on their HIV medications are an undetectable status, which we'll talk about that next, meaning they won't transmit HIV to their partners. And like we saw earlier with healthcare workers with the needle stick, the risk is very, very, very low. And since 1999, I believe, there's only been one case of healthcare-associated needle stick. If you are a healthcare worker and you are on the fence on what to do for a patient and they want to talk about PEP, there's actually that hotline, the post-exposure prophylaxis hotline, where they will put you in contact with an infectious disease specialist. You can talk about the case with them and they can help you decide if the patient needs PEP or not. Okay, so U equals U. Essentially what that means is undetectable, it means untransmittable. So once a patient is on ART for a certain amount of time, again, depending on how long they've had HIV without treatment, if they've been on and off medications, if they've been consistent with their medications, eventually the viral load of an HIV patient becomes so low that the lab tests will not be able to detect the virus in their blood. They will still test positive because of their antibodies, but they'll be virally undetectable. And so multiple studies, partner 1 and partner 2, they found that patients who had an undetectable viral load did not transmit HIV to their other sexual partners, which is a huge thing that came out and really helps decrease the stigma of those with HIV. Because if you can be on medication, you can live a normal, healthy life and not be afraid of transmitting HIV to other people, particularly your partner. So these studies were done in serodiscordant couples, again, meaning a couple, one who does have HIV and one who does not have HIV. And so they studied these patients for a few years, and they had condomless sex consistently, multiple times a week. And so long as the partner who had HIV was HIV undetectable and stayed on their medication, they did not transmit HIV to their partners who were HIV negative. So that's a huge, huge thing. So partner 1 was with, I believe, mostly heterosexual, some homosexual couples. And then the partner 2 study was with homosexual couples. Again, one partner who is HIV positive and one partner who is HIV negative. Condomless sex, regularly, no HIV transmissions within the couples. I don't know if it was in the partner 1 slide, but there were a handful of people who were HIV negative at the beginning of the study and then became HIV positive later on, but they also were noted to have sex with other HIV positive people who were not included in the study and who were not undetectable. And that's what this slide says. Does anybody have any questions about that? Any thoughts? Did anybody know about U equals U? Oh, good. Yeah, actually, in Europe, they talked about U equals U for quite some time before the US did. When the 2016 partner trial came out, it was huge in Europe, and I don't think it really hit the US until the partner 2 trial came out, which is unfortunate. because I don't know about you guys, but I never learned about it in medical school. Oh, sorry, I didn't realize how much I talk. Okay, we got 5 minutes. U equals U. That was the main point that I wanted to say at the end. HIV prevention, you have PrEP, you have treatment, and then you have prevention with discussing patients about the risk factors. Do you guys have any other questions? I know I was a little all over the place. That's just my personality. I hope you guys were entertained. Can you stop my screen sharing? And then that way I can just chat with whoever wants to have any questions.
Yes, let me try doing that here.
I don't know why my mouse disappeared.
No worries. Let's see.
Can you guys hear me? Okay.
Yes, we just can't see you. Can you turn your video on? Does it let you?
No, it said that the host, I have to get your approval.
Oh, okay. Give me 1 second. Bear with me, guys. Sorry, I am also new to Zoom here. Okay. Sheesh. How?
I appreciate all of you guys for tuning in and dealing with me and my technical difficulties. I see another question in the Q&A, I guess, which I'll answer. As both a gay and Latinx man, can you talk a little bit about how you overcame imposter syndrome or a feeling like you don't belong? You know, that is a great question. It just, it took time, and I don't know what the right answer to that was. Prior to medical school, I really did not have a very great self-esteem. I did suffer a lot of imposter syndrome, but as I went through medical school, did my studying, went through my rotations, I got a lot of feedback, positive feedback from my attendings, and just a little over time, I just sort of realized like I'm good at what I do. Like people like me. I'm a likable person. I care about my patients, and it's little things like that over time that make you realize that you have value and worth in this community, and you have something to offer. I think, especially as minorities, we get under this imposter syndrome a lot, and when we realize that we have a whole community that needs us and needs us to stand up for them, I think that really helps me feel like I'm doing something positive. I'm doing something that helps other people. And as long as you do stuff in a way that you're helping others and not hurting others, I think that really makes a huge difference to people. And just being genuine. I think that's the big thing, is being genuine and honest with people, because people can tell when you're lying or don't feel confident about what you're saying. Yeah. And if you don't know something, admit it. Don't lie yourself through it. That's my little spiel about that. Working in sexual health and HIV care, how can we get other institutions to adapt a harm reduction model and have more talk about LGBTQ plus health? I don't know. That's what I've been trying to do. That's what I keep hoping that I can do. I'm very passionate about this stuff. So I just hope the louder that I am, other people become passionate about it. And the more people that talk about these sort of things, the more that we can make a difference in our communities. And then last one, because I know it's time for it to end, I see somebody wrote, is there any programs for patients who are at risk of HIV but can't afford preventive treatment? Yes, Gilead, insurance companies, pharmaceutical companies are terrible. That's a whole topic for another day. But Gilead, in their strange hearts, do offer patient assistance programs for PrEP. So for a lot of patients, actually, they can get PrEP for free or at a low cost. So yeah, definitely look into those programs to help patients who are at risk for HIV but can't afford the medications on their own. So yeah, I think our time is up. But I just want to say again, thank you to LXMed for having me. Thank you to all of you guys for joining in and dealing with my technical inabilities. I hope you guys were able to get something positive out of this experience and learn more about HIV and HIV prevention. And I appreciate you guys. So thank you.
And we appreciate you as well, Marcus. Thank you so much for your time. And this was such an informative presentation. And I think everybody agrees in the chat. Everybody's saying, thank you, thank you, thank you. So I also want to thank everyone for tuning in. We'll be having a lot more webinars like this soon. So if you're interested in those, please sign up to our emailing list. You can find that on our website, latinxinmedicina.com. or you can find it on our Instagram if you click our little link tree. Our network, the LXMed network, will be officially launching in January, so keep an eye out for that. Marcus, do you also want to drop your Instagram handle for people to follow you on Instagram?
Yeah, if you guys don't already, you can check out my Instagram, Dr. DOCTOR Tellez, TELLEZ. I have a lot of, if you liked what I talked about, I have a lot of information on HIV, STDs, LGBT health, general education of medicine. So if that's something that you guys are interested in, you can definitely check out my Instagram. And yeah, if you guys took screenshots of some of the slides, feel free to tag me on Instagram, post it on your stories. It's just important to spread this message and make sure that people know. So again, thank you, everybody.
Yes, and we will be saving this video, this webinar. I believe we'll be formatting it to YouTube, but we're gonna figure out the logistics, but it will be available to everyone so you guys can share with your friends and your family. And yeah, so thank you so much, everybody. And Marcus, thank you again. Thank you so much.
Thank you. You guys all have a good night.
Have a good night.